So each presenter will have 10 minutes for the poster, and then there will be a 5 minutes Q&A, and then we will have the networking social in the end. That sounds good to everyone. So let's first welcome Hannah from Brook University, and the poster is about the psychological effects of COVID-19 organizational preparedness on Canadian healthcare workers, a cross-sectional analysis. Hannah, would you mind to share your poster to everyone?
My name is Hannah Mechelse, and I am a Master of Applied Health Sciences student at Brock University in St. Catharines, Ontario, Canada. Today, I will be presenting my work from an independent research project I completed on the psychological effects of COVID-19 organizational preparedness on Canadian healthcare workers. Personally, this topic was of particular interest to me as I worked in long-term care during the COVID-19 pandemic. So I have firsthand experience of the confusion, anxieties, and stressors that were associated with it. So, just to give you guys a bit of background on my topic, while numerous fields were affected by the COVID-19 pandemic, healthcare workers were disproportionately impacted by persistent viral workplace exposure. Although government bodies and healthcare agencies continued to implement policies for mask wearing and exercised infection control techniques and procedures, adherence to these policies proved difficult due to shortages of personal protective equipment and inadequate pre and post infection control procedures. Specifically in Canada, various studies have exemplified the impacts of COVID-19 on the mental health of healthcare workers, both during and post pandemic compared to pre pandemic. However, little literature exists regarding the relationship between organizational preparedness and the mental health of healthcare workers. As such, the specific objective of this study was to determine whether there is an association between organizational preparedness and perceived changes to mental health status of Canadian healthcare workers relative to before the COVID-19 pandemic. I assess this using the impacts of COVID-19 on healthcare workers infection prevention and control survey distributed by Statistics Canada. In the survey, mental health status change relative to prior to the COVID-19 pandemic was assessed on a scale of 1 to 5, from much worse to much better. However, responses were grouped for analysis as either worse or not worse. Organizational preparedness was assessed via 3 key variables: the existence or absence of formal infection prevention and control, or IPAC training, the existence or absence of formal personal protective equipment, or PPE training, and the extended use of PPE beyond normal use, which I chose as an indicator of organizational PPE shortage. Proportions were calculated to assess the distribution of key predictor variables and their covariates based on self-reported changes to mental health status. Weighted analysis using benchmarking values were included within the dataset, were incorporated via the RStudio survey package. As well, comparative testing via Pearson's chi-square tests of independence were conducted with Rao and Scott adjustment for weights. Separate multiple logistic regressions were also conducted for the 3 predictor variables. However, years worked and job setting were removed based on backward selection and collinearity results. Models were further stratified by occupation group to assess possible differences in association based on occupation, with variables for each subgroup being chosen based on previously conducted backwards analysis results, passing of chi-squared assumptions, and statistical significance. However, regardless of statistical significance, sex and age were controlled for within all models based on previous literature. Ultimately, all covariates were found to be statistically significant except province, suggesting that self-reported change in mental health status is not independent of COVID-19 exposure, work hours, occupation group, years worked, job setting, age, gender, immigration status, or minority status. The odds ratios calculated for all models represent the odds of self-reported worsening of mental health status, assessed relative to individuals who responded yes to undergoing formal IPAC and PPE training and no to extended PPE use. As shown in Table 1, IPAC and PPE training were found not to be significantly associated with self-reported change in mental health status. However, PPE training, no PPE use, was close to statistical significance. As well, extended PPE use, yes, was found to be statistically significant, suggesting that individuals who use PPE for an extended period of time have a 1.57 greater odds with a confidence interval between 1.38 and 1.83 of self-reported worsening of mental health status than those who did not. Figures 1 through 3 depict forest plots of the association between self-reported changes to mental health status and organizational preparedness for the three main models and their covariates. Significance findings for the covariates are pretty much consistent among all the main models, as you can see within the figures. Specifically, for almost all three multiple logistic regressions, individuals located with the Atlantic provinces, Quebec, and the territories exhibited a statistically significant decrease in odds of worse mental health outcomes relative to Ontario, whereas individuals located within the Alberta and British Columbia provinces exhibited a statistically significant increase in odds of worse mental health outcomes relative to Ontario. Additionally, part-time work hours exhibited a statistically significant decrease in odds relative to full-time work hours. Ages 45 to 54 and 55 or more exhibited a statistically significant decrease in odds relative to 35 or less, with the strength of association and odds increasing by age. Females were also found to be statistically significantly associated with worse mental health outcomes, exhibiting an increased odds relative to males. Finally, immigration status and minority status were both found to be statistically significantly associated, as immigrant and visible minorities individuals exhibited decreased odds relative to non-immigrants and non-visible minority individuals. Importantly, these findings align with previously conducted studies comparing mental health status among the included population groups that I stated here. The sample sizes for some occupation groups were found to be inadequate for multivariate analysis, however. Therefore, I constrained analyses for these subgroups to those with larger sample sizes, specifically the nursing, allied health professional, laboratory worker, and dental occupation groups. As shown in Table 2, extended PPE use was found to be statistically significant for nurses, allied health professionals, laboratory workers, and the dental subgroups, and the strength of association was stronger for all of those except laboratory workers and in comparison to the main model. Additionally, within the allied subgroup, all three models exhibited statistical significance for at least one key variable. Interestingly, an association was found between a lack of IPAC and PPE training and decreased odds of self-reported worsening of mental health for the allied health profession and laboratory worker subgroups. I hypothesize that the association may be due to a differential occupational environment of those who do not partake in a formal PPE and IPAC training or use PPE. As a model that controls for job setting lacked statistical significance between IPAC training and self-reported mental health status, with an odds ratio of 0.88 and a confidence interval between 0.74 and 1.05. However, PPE training response no remains statistically significant, with an odds ratio of 0.83 and a confidence interval between 0.71 and 0.98. Ultimately, these results build upon the findings of previously conducted studies, which suggested the implementation of robust emergency preparedness and response procedures in order to help mitigate negative mental health outcomes of healthcare workers. Importantly, these findings of the study indicate that organizational PPE shortages have a distinct negative impact on the mental health of healthcare workers during crisis. However, the lack of statistical significance found for the main models does not necessarily indicate that there is not an association between PPE and IPAC training and mental health outcomes, as within the survey dataset, training was assessed on a binary scale, i.e., yes PPE training or no PPE training. Therefore, additional research will be required to assess whether there is an association between the perceived adequacy of IPAC and PPE training procedures and policies and mental health outcomes of healthcare workers, and whether these findings remain consistent throughout the course of COVID-19 pandemic. Thank you for listening to my presentation. I hope you found it informative. I've included my contact information below if you have any questions for me or would like to see more of my data. I would just like to take a moment, however, to thank my statistics professor, Dr. Jason Liu. He was of great assistance throughout the planning and analytical process, and I am incredibly appreciative of his willingness to put up with my million questions that I had throughout the process. Finally, I've included my citations on a separate page, as I simply had too much information to be able to fit them all on my poster. Thank you so much.
Yeah, sure. Thank you so much, Hannah, for your great presentation. Are there any questions from the audience?
I don't have the list of R packages included, but I do have a record of all of my code. I know the survey package was the main one I used for weighting and for analysis, and then I believe it was mainly just like the plur and dippler packages I used for mutating my data in order to organize it properly. And then I believe I used the car package for looking at variance. But pretty much everything for analysis, weighting is pretty straightforward with the survey package, and a lot of the actual coding that I had to do is compatible with that. So once I found that one and was able to pretty much figure out how to use it, it was pretty straightforward because I could basically just do my the GLM functions just with the weights added.
I would like to thank you, Hannah, for your great presentation, and then we can move on to the second presenter. Sara is from UC Irvine, and her her presentation is about a latent class model for plant missingness designs with the International Affective Picture System.
Good afternoon. My name is Sara, and I'm a first-year PhD student from the UCI Statistics Department. And today I will be discussing a methodological approach my professor and I have been recently working on. Specifically, we will be discussing a latent class model for plant missingness designs, the International Affective Picture System. To give an overview of my presentation, I'll first begin by discussing the project and how it came about from the problem that we encountered with a collaborator. I will then describe how we decided to address the problem in our methods and handling section, and then I'll briefly touch on some of the results of our analysis, as well as some of the final thoughts and future goals for this project. So let's begin with the project overview. So my advisor and I were lucky enough to work with Dr. Elizabeth Martin and Jen Blank, both from the UCI Department of Psychology. Their team recently has been working on updating the normative ratings for the International Affective Picture System, the IAPS, and part of their goals were aimed to explore how demographic variables such as gender and ethnicity might influence responses to images from the International Affective Picture System, which we're referring to as IAPS. They have surveyed a sample of 1,008 individuals to gather data on mean ratings and positive emotion, negative, and emotional arousal that is elicited by the images, as well as to categorize images into positive, emotional, and negative neutral categories. And they reached out to my advisor as they had a substantial amount of missingness in their data, approximately 90%. So this was due to their study design where each individual participant only received a subset of the IAPS, only 2 sets of images, each was 60, so 120 in total out of the 1,182 slides. To get an idea of what each participant recorded, if you look on the right-hand side of the screen, you can see 6 images from the IAPS image collection. This is just some random subset. And they vary wildly in content and composition, as you can see here, and they have been selected to elicit a wide range of emotional response in participants, the entire subset. So if you were an individual in the study, you would, for instance, be shown 1 image at a time, and then be asked to give 3 measurements, all on a Likert scale, where the Likert is an agreement scale, where 1 is strongly agree, and up to 9 would be strongly agree. Sorry, 1 would be strongly disagree, 9 strongly agree, where 5 is a neutral or indifferent score. And you would put down a response for how positive, negative, and emotionally arousing you found the image. Okay. So due to the large portion of missingness, 90% was missing. Each individual, again, was only received 10% of the collection. It would be really difficult to conduct group differences for each individual slide, as each slide had about 50 individuals only, and there was then really low power and made it difficult for our collaborators to detect true effects or differences between groups. So our goal was to try and find a way to leverage the individual recorded data in order to retrieve or make inference on the unobserved data. And so we decided that we need to collapse the data and perform dimension reduction by clustering the slides together. So this leads us to part 2 method, specifically dimension reduction. We break this portion into two main sections. First, we're going to cluster the IAP slides by their average measures for the data, positive, negative, and arousal. And this makes sense intuitively as the IAP slides are included in their sets historically in order to elicit some kind of emotional response. And it makes sense to think that some of these slides are going to give off similar responses to others. A dog and baby might make you happy, for example. However, we need to decide upon the number of clusters to capture the underlying structure of the data, while also providing enough statistical power to draw meaningful conclusions. So then after that, we want to calculate an average cluster measure for the data for each individual score, positive, negative, and arousal. This will ultimately reduce and hopefully remove their missingness from the data set. However, we also need to decide if when averaging this individual data to get an individual cluster score, if we want to use all the slides in each cluster or some kind of subset. And we're going to be treating this as a tuning parameter. So in order to cluster the slides, we decided upon using k-means clustering, which we clustered on the summary statistics for each slide, which included the average positive, negative, and arousal score for each slide or image. To determine the optimal number of clusters, we minimized the within sum of squares and ultimately settled on k equals 5 as it minimized the within sum of squares based on an elbow plot, which our choice was also supported in previous research. So if you look on the left side, you can see the final 5 clusters. Here, each dot is one of the 1,182 images or slides, plotted with the average positive and negative on the x and y axis, respectively, as a state the most clear separation. If you glance at the right-hand side, you can also see next to each cluster, the cluster number. We also have a name or description for each cluster, which are not arbitrary, but based off the cluster scores for each of the 3 measurements. For example, cluster 1 was called negative, the pink one. It was called negative as it had the highest average negative measure across all clusters. This is also reflected in the plot on the left here. As you can see, it's in the most negative, the highest part on the y-axis. Further, cluster 4, the blue one, is called neutral as it has a relatively even score in both like the positive, negative, and arousal category. And they're all close to around 2 for all 3 measures. And it's located on the dot plot in the very center between the 2 axes in blue. All the clusters had around 200 slides. The smallest was 195 and largest was 310. And this table gives an idea of how the names were decided for each cluster. It's worth noting that the slides do have names and descriptions, the individual slides that is, some being similar to others, and we were able to list the most common or top description in the far right column, which did seem to correlate to the final cluster name and the average measure makeup. Okay. So now moving on to the second portion, having clustered the slides, we're now able to make a cluster measure score for each individual, which will be an average positive, negative, and arousal score for each cluster using the data that the individual has. So although the individual doesn't have all the slides, it's more likely that they'll have some portion of the slides in each of the clusters, allowing us to make a latent cluster measure score for each of the 5 clusters. However, we need to decide if the individual cluster scores should use all the slides in each cluster. We expect that the total proportion of missingness to decrease as we use more data. However, this would also make the clusters harder to distinguish as there isn't great separation between the clusters, which we saw before, and when we were looking at all 182 slides. But to maximize separation between clusters, we instead decided to use the most representative slides, that being the ones closest to the center or centroid of the cluster. And I hope to make this more clear in the following slides. So if you look on the left again, we see that all the slides used in the clusters are displayed, and that there isn't great separation between them, and that there's actually fair bits of overlap. So in order to get the most separation, we can actually select the most representative slides closest to the centroid of each cluster, where here on the right, we have the top 10, which has, you can see here, has very clear separation between the 5 clusters. You can see very distinct groups. However, with only 10 slides per image, individuals still may not have data on those 10 slides, and thus there may be missingness, which is what we were trying to diminish in the first place. So if we change and treat the number of slides used as a tuning parameter, we can see how the proportion of missingness changes over time. So we can see how, as you increase it here, this is for top 20 and top 50, they all have a good separation. And next, if we look at the overall final proportion of missingness in the final data set for the original versus top 10, 20, and 50, and all the slides per cluster, we can see how substantially the drop is from just using the top 10, but we only really get a reduction to 0 achieved when we use top 50. We can also get that with using all the clusters, but again, this one also allows for a clear separation between them, which we ended up using only the top 50 for our final analysis. So for the final section, we can discuss some of the analysis done using the latent cluster data. Specifically, our collaborator was interested in comparing differences in race and sex. Our data was limited to the races which only had large enough sample sizes to make inference on, that being white, Hispanic, East Asian, and Southeast Asian. As seen here, some summary statistics as well. So we adjusted for multiple comparison using a false discovery rate of around 10%. The following showed some significant differences between the race categories at the 5% level. For the most left column, this refers to the cluster number and the cluster measure. So 1-arousal refers to cluster 1, which was the negative cluster, implying that Hispanic versus East Asian had differences in their average negative cluster arousal scores. Okay, and we can further see that these visualized in box plots, where they are showing the different measures and for what cluster there was a difference between race groups. So again, the first one circled in yellow here outlines that the 1-arousal or cluster 1 average arousal score difference was significant, implying that Hispanic versus East Asian had differences in their average negative cluster arousal scores. So this was for first two measures, and then we can also see the third measure here, negative, also had some differences. We also did this for sex differences between males and females for the different clusters. Here we also adjusted for multiple comparison using an FDR of 10%. And these were all also significant at the 5% level, which one can interpret similarly for the races. For example, again, we can see that the 1-arousal refers to cluster 1, which is the negative cluster arousal measure, implying that males versus females had differences in their average negative cluster arousal scores. Here, the comparison is men minus women. So we can actually see that the men have a lower arousal score for the negative cluster. Okay. And again, we can display the plots across the measures within the clusters here in the box plots. None of the neutral categorical cluster groups actually had any significant differences, which was somewhat interesting to our collaborator here. And again, you can see positives. So next we can move on to our conclusion. So to summarize, in this study, we employed dimension reduction techniques by clustering slides together using within sum of squares. We captured IAPS images based off effective attributes, identifying distinct clusters, and maximized cluster separation using centroid distance, and used a tuning parameter using the top 10 to 50 slides, optimizing our analysis, and utilized the top 50 to get our individual cluster measure scores, and effectively overcoming the missingness in our data set. So overall, this approach, we were able to demonstrate here how the feasibility and effectiveness of conducting analysis in the present of planned missingness data. So in our future endeavors, we want to focus on refining our model for understanding and incorporating advanced methodological approach. We want to integrate machine learning as well as conduct validation studies to assess the robustness and generability of our clustering results across other populations and ensuring the reliability of our findings. Lastly, I would like to thank my advisor and as well as our collaborators from the Department of Psychology and all of you here today, as well as the NISS for this opportunity. Thank you all for your time, and I hope you all have a great day. Thank you again.
Thank you, Sarah. Are there any questions for Sarah from the audience?
I do. Sarah, thank you for the nice talk. It's great. I wanted to ask you about the difference between races and sex happening. So what was that happening across like all images, or was it like specific to certain images? Was the difference more pronounced in like a specific set of images, or was it happening like across multiple images?
So we're actually finding differences for the different clusters. So if the slide was in cluster 1, we would say that the negative images, we were finding a difference for it. I think the main difference that we saw was that, at least for the sexes, that the neutral category didn't show any differences between men and women. I'm not sure what that says. You'd have to ask my collaborator.
Thank you.
Thank you, Sarah, for the great presentation. And then our final presenter is Patrick from George Washington University, and his topic is about investigating changes in rural versus urban malnutrition disparity for low and middle income countries with WHO hit. Yeah, so Patrick, would you mind to share your screen, or do you want us to do that?
For all, I can share my screen.
Sure.
And, okay.
Sounds good.
All right. Okay, can everybody see this also?
Yes.
Okay, great. So yes, hi, I'm Patrick Roney. I'm a student at Georgetown, so Department of Biostatistics, and this past spring I was also selected to be a fellow in Georgetown's Global Health Institute, in which then I got to work on this project to investigate child malnutrition disparities by place of residence for low and middle income countries. And so we came to this question. Most of the semester was actually spent trying to just come up with this question, because there's a lot of different ways that we were tasked essentially by the World Health Organization to look into some aspect of health disparity. And so we used then the World Health Organization's Health Equity Assessment Toolkit, HEAT, which has lots of different data and questions that can be asked and answered, because it has data both then about, for instance, you can look at vaccination coverage, you can look at COVID-19 impact. And for us, we decided to focus on reproductive, maternal, and childhood health. So even just deciding on focusing on this aspect, though, we then had to figure out kind of what aspect of childhood health we wanted to look into. And so after reviewing the literature, we noticed that there seemed to be lack of information about childhood malnutrition, which we looked at or within WHO HEAT is defined as being less than 5 years old. And there tends to be a lot of focus on the economic impact on malnutrition, but we decided to focus on place of residence, being defined then as rural versus urban estimates. And so that was then our motivation for this project, to analyze these changes in time for rural urban disparities for all 5 childhood malnutrition indicators for low and middle income countries, which were defined by the World Bank Organization. Now, the 5 childhood malnutrition indicators are overweight, underweight, stunting, wasting, and severe wasting. And for today's talk, I'll just be focusing on severe wasting for an example, which severe wasting can be defined as when a child is more than 3 standard deviations below the WHO's child growth standards. And severe wasting is a reference to also, though, the child's weight to height ratio. And so one other great thing I just want to mention about WHO HEAT, which is really good for research, is that it provides that data and also just some summary graphics at the beginning to be able to get a handle on your data, but then to be able to download it into whatever software you're choosing to continue analysis. So after downloading the data, we decided to focus, though, on demographics and health survey between 1990 and 2021, and a country needed to have 2 survey data points in order to be included. And this was done so that we could be able to understand then how the country's metrics were changing over time. And then we also defined an increase in disparity as an increase over time in the difference between the rural prevalence and the urban prevalence of a malnutrition indicator. So now in the middle of the screen, we have in the bottom these rural urban prevalence differences for severe wasting. And again, that difference is the disadvantaged group, which is considered to be rural by the HEAT software or the HEAT website, and then minus the urban estimate. So a country that is on this red line then has no difference between the rural and the urban malnutrition prevalence. But so then countries on the right side with their estimate, they have a greater inequality or a greater prevalence of, for this case, severe wasting for their rural areas, and then those on the left for urban. So we're going to focus, though, throughout these 2 graphs on the Democratic Republic of the Congo, or the DRC. So we can see for their earliest estimate, it is to the left of our 0 line. So that means that we're having a greater prevalence of severe wasting in urban areas compared to And then for their most recent estimate, though, we see that it swings the other way. So now it's clearly showing that there's a statistically significant increase in rural prevalence of severe wasting compared to urban. And then we can then take essentially the subtraction of these 2 graphs and then adjust them for over 10-year periods, be able to see that the DRC has an increasing rate of 4.8% per 10 years of increasing severe wasting in rural areas compared to urban. So all these countries that are in red then up here, they're having more severe wasting occurring for their rural areas compared to the urban. But those in the green are doing a good job. So they're showing that they're actually reducing it. So the Maldives, for instance, they did sort of the best out of the 52 countries that we analyze, because they're reducing that inequality by 4.2% every 10 years. So so this is just one example for severe wasting, but we have similar graphics that were provided for, again, all 5 of the childhood malnutrition indicators. And that can be summarized then here, inequality reduction for the 5 malnutrition indicators. So 8 out of the 52 countries, or about 16%, were worsening in either 4 or all 5 of the malnutrition categories, while about 60% of countries were improving or reducing that inequality in either 4 out of all 5 of the malnutrition indicators. So it's showing that overall countries are tending to make progress in reducing disparities based on place of residence for childhood malnutrition. Then for how each category is sort of performing, we can see that the category that's having the least amount of inequality reduction is for the overweight category, in which 42% of countries did not have any progress being made in reducing inequality by place of residence, while the underweight category is having the most progress. So 20% of countries are not having that inequality reduction, or we could say it as 80% of countries are making progress towards reducing the inequality. So for our conclusions for this project, then, it's that most low and middle income countries are showing progress towards reducing malnutrition disparity based on place of residence, which is, of course, is a good sign that we're making progress towards being able to reduce that disparity. Overweight indicator has the least reduction in inequality, though. And so that means that policy should focus on trying to reduce this overweight disparity while continuing to reduce the disparity for the other 4 malnutrition indicators. Now, it should also be noted that this wasn't a paper or research that focused on policy. We didn't look into what essentially countries are implementing in order to reduce this disparity. We simply were just trying to take that data that is available in WHO's HEAT and try to understand what's happening on a global scale. And then in the future, though, we're planning on trying to continue this analysis to look at more regional levels. So for instance, clumping based on geographic information to be able to see what parts of the globe are having different progress being made. So thank you very much for your attention, and happy to take any questions.
Okay, thank you, Patrick. I have one question. So why is the width of the credible region, confidence interval, like really large for some of the countries, and why are they so small? I feel like generally the first plot generally have wider credible confidence interval. Is there a reason why that's the case?
Sure. I think that has to do with just how the data was collected. So demographics and health survey, that's just one type of survey data in which they're using different estimates to basically get a handle of what kind of the picture is for the population at large. So I think that it's more so due to the surveying techniques that were being used as far as increasing sample size that's being used. We didn't look into, for instance, though, comparing the different, for instance, DHS is what we use. There's also other ones called MICs, or there's even more regional survey implementations that we didn't look at sort of comparing it. But so I think in the end, though, as far as for what those interval estimates were, I think it was just having to do with survey techniques.
Thank you.
Yeah, thanks. And right, and I saw in the chat, what future work do you plan to extend this to? So again, we're collaborating with WHO. So they sort of just want us to right now write up. It's more so that they have a lot of data that just needs to kind of not just be in the software, and needs to be translated out of there. So we're going to write this up, and then I think in the future we're planning on looking at other areas of reproductive, maternal, or childhood health to see what progress is being made.
Thank you, Patrick. Are there any more questions from the audience? If not, I would like to thank you, Patrick, for your great presentation.